Okay. So this is what I just talked about. This is a good picture of like potential class side effects for drugs that target different targets like within our cancer cells. And as you can see, like VEGF, for example, and we'll talk about this more, you can see hypertension, proteinuria, wound healing, because it affects VEGF, for example. So a nice little reference for people down the road. So let's talk about melanoma. So melanoma we talked about yesterday in terms of using immune checkpoint inhibitors. Those really revolutionized the treatment of melanoma. Another set of drugs that have revolutionized the treatment for melanoma is the BRAF and MEK inhibitors. And so listed here on your slide, if a melanoma cancer has a BRAF mutation, I would say it's about 40 to 50% of patients, usually younger patients. If they have a mutated BRAF system, essentially they have unchecked cell proliferation. And so as you can see, you have excessive cell proliferation and survival. And so now we have drugs that target this BRAF and the downstream MEK inhibitor. So the combinations of drugs. The first one I'm actually going to focus on is the first agent that came to the market was venurafenib, and that was our first BRAF inhibitor that we used in melanoma. It did not have its partner, the MEK inhibitor, cobimetinib, until years later. So what happened was venurafenib was approved, and it's not the best tolerated drug, but then it was compared to dabrafenib and trametinib, and that is still kind of like our gold standard that we use, and it has different indications besides melanoma. Listed here on the slide is the dosing, 150 by ml twice daily, and then 2 milligrams once daily of trametinib. The biggest thing with this combination, it has to be taken on an empty stomach. I sometimes find that that can lead to nausea issues with patients, but it is very important to take it on an empty stomach. Of course, there's drug-drug interactions that you need to be cognizant of, and here's how it is supplied. Cobimetinib, when it was approved, this is your combination of BRAF and MEK inhibitors. Cobimetinib is actually dosed on a cycle base, so days 1 through 21 of a 28-day cycle. This one is nice. It's taken with or without food. Again, you do have to be cognizant of drug-drug interactions. Now, encorafenib and binimetinib, this is the newest guy on the block and almost appears to be the best tolerated. Listed here on the slide is the dosing. I do want to, this is my point about tablets and capsule sizes and how it can be very burdensome for patients. So if you look at the dosing here, encorafenib is 450 milligrams by mouth once daily. Binimetinib is 45 milligrams by mouth twice daily. Look how these are supplied. So if you're going to be taking encorafenib 450, that is 6 capsules once a day. Binimetinib is 15. That's going to be 3 capsules twice a day. So that's something very important to note with patient is knowing your tablet and capsule sizes, because it can be, they call it a high pill burden, and this regimen is definitely a high pill burden. So let's look at side effects. Venurafenib, again, the first guy in the market. I find that this one has the highest risk of cardiotoxicity, in addition to arthralgias, fatigue, rashes that can occur within the first couple weeks of treatment. You do have to do some extra monitoring with your EKGs. Dabrafenib can cause, the biggest one that I see is fevers, and something we forget about is it can increase blood sugars. This one can also, though, cause rashes, arthralgias, diarrhea. Encorafenib, although there's a whole bunch listed, this one actually I would say is the best tolerated BRAF inhibitor, but you can still see some peripheral neuropathy, increased serum creatinine. This will go back to baseline once the drug is stopped. But in addition, you can still see the arthralgias and the fatigue associated with this one. MEK inhibitors, I would say across the board, the biggest thing that you're going to see with MEK inhibitors is diarrhea, the potential for rash, and increases in liver function tests. Those are kind of class effects associated with MEK inhibitors. Now, interestingly, some different cancer types, so non-melanoma, will just use MEK inhibitors in combination with other therapies. And so you might see some of these more class effects when you're using them with, I think we have like a research trial with, I think it's trametinib plus immune checkpoint inhibitors in colorectal cancer. You're going to see some of those trametinib side effects come out that have no relation to the immune checkpoint inhibitors. Sometimes difficult to tease out, though. So let's talk about a patient case. So MJ is a 39-year-old with stage 3B BRAF mutated resected melanoma. She begins adjuvant therapy with dabrafenib and trametinib. I'm calling her for a follow-up 1 week after starting therapy. We went through teaching, and again, when you're going through teaching after they've met with a provider, sometimes they can be overwhelmed, but usually I write down how many capsules and tablets that they have to take to equal their total dose. So listed here on your slide is what she should have been taking. So dabrafenib, 2 capsules by mouth 2 times daily on an empty stomach, trametinib, 2 milligram tablets, 1 tablet by mouth daily. She then informs me that she's only been taking 1 capsule twice daily. So this is kind of where adherence matters, and sometimes why following up with patients, something that we do as pharmacists in clinic to ensure that they're taking their appropriate doses is very important. So 5 months after starting therapy, she comes back. She reports she's developed an itchy, bumpy red rash on her torso, face, legs, and upper arms. It's covering approximately 90% of her body. When rashes happen from BRAF inhibitors, it can be very rapid and fast. So they might notice a little bit on their chest one day, and then it can rapidly progress within a couple days. So what are our treatment options? What should she do? Hold dabrafenib and trametinib, start prednisone, start hydroxyzine, and apply hydrocortisone topical cream as needed. And there can be more than one answer. For this patient, the fact that it's covering 90% of her body, you're of course going to hold drug. Because of the itching, hydroxyzine is probably not enough, and you're going to want to start some steroids for that. But then again, too, you can use topical steroid cream in that instance too. So yeah, all of the above is what should happen for MJ. So her rash is resolved. She presents back to clinic 1 month later. She resumes dose-reduced dabrafenib just based on the fact that it was a very extensive rash. She started on 100 milligrams twice daily, and then the trametinib 1.5 milligrams once daily. 1 week after restarting, she calls in to report fevers daily up to 102.9. So which medication is the likely culprit causing her fevers? A, dabrafenib, B, trametinib, or C, post-prednisone fevers? A, yes, it's for sure dabrafenib. This is definitely a culprit that is known to cause drug fevers. If you look, in Lexicomp or Up to Date, it'll give you this wide range time of when the fevers can occur. Of course, if you get a call, I'm thinking of our, fellows who are on call. If you get a call at 9 p.m., patient is on these drugs, reports fevers. Of course, you have to do your infectious workup for patients. But if all of that comes back negative, then most likely you can chalk it up to dabrafenib fevers. So that's melanoma drugs, the BRAF and MEK inhibitors. Let's go and talk about some GI cancer drugs. So the first 2 I want to talk about are panitumumab and cetuximab. Predominantly here at UW within our GI clinic, you're going to see more panitumumab used, but really you might go to an institution that's cetuximab heavy. Both drugs, they work the same, they have the same indication, they're both listed in the guidelines, so there's no difference between the 2. So panitumumab dosing is listed there, and cetuximab dosing is listed, both are dosed every 14 days, so it usually aligns if it's combined with cytotoxic chemotherapy, like a FOLFOX or a FOLFIRI. How it works, it binds to cell surface epidermal growth factor receptor, and it prevents EGF and TGF alpha binding and signal transduction, so that can't happen. For colorectal cancer patients, in order to use this, they must be KRAS wild type. It does not work in KRAS mutated patients. Toxicities, infusion-related reactions can occur, especially within the first, I would almost say 1 to 3 doses. The characteristic acneiform rash that we will talk about more extensively coming up. Fatigue over time, diarrhea, and both of these drugs are culprits for wasting magnesium. So often what happens over time with patients on these drugs is that they are in infusion centers for long periods of time, because not only are they getting their drug, but they're usually getting IV magnesium. Usually oral is not enough for these patients. So let's talk about this EGFR rash. So in the colorectal cancer population, there was the STEP trial, It was an open label randomized trial evaluating preemptive skin regimen in patients receiving panitumumab. So what this preemptive approach does is it highlights skin moisturization, sunscreen, topical hydrocortisone cream at bedtime, and starting an oral antibiotic, doxycycline. What they found in this trial was that the incidence of grade 2 or more acneiform rash was 29% for preemptive patients versus 62% for patients who were reactive, meaning they started stuff after the rash already had begun. If you look at that percentage, that's a major difference. It's enough for us to do a preemptive approach at UW. So at initiation of therapy of panitumumab or cetuximab in GI cancer patients, they are educated to apply hydrocortisone 1% cream at bedtime, usually on their T-zone of their face and their chest area, just a thin layer. And if they have a significant other, also getting their upper back, because those are the first areas that the rash usually occurs. We discussed moisturizers with sunscreen. UV radiation can cause the acneiform rash to occur and sometimes make it worse. We educate patients to apply that once daily in the morning. And then they also start doxycycline, so 100 milligram tablets. I didn't press that button. 1 tablet by mouth twice daily continuously. We do this, the trial was done for 6 weeks. You will most likely, though, see patients continue on it long term as long as they're not having any issues. So what does it look like? Looking at the picture here, it looks like acne, but it's not acne. And so it's really, I say to my patients, I'm going to maybe put you back to your 13-year-old days when you might have had acne. I don't want you to pop them because that can cause infections and make it worse. I don't want you to dry your skin out. Drying out the skin makes it worse and it can quickly, unfortunately, spread. Some patients and some products you have to be very cognizant of actually, and also too, like their moisturizers with sunscreen, making sure that they don't have like any alcohol in them because that alcohol can dry it out and make it worse. So I say to patients, you're going to be gooping up yourself if you develop the rash because that's actually what makes it better versus drying it out. Here's other pictures of like the severity, what can happen. It can be it's a morbidity thing for patients. Some patients will develop it not only on their face, but their chest, maybe their back. I've had patients, like I've had a truck driver in the past who, his arm, his left arm, all of a sudden that broke out because that's what was exposed to UV radiation. This is something that, in clinic, oftentimes, like Dr. Deming will send me into patients to discuss different topical therapies. If this happens to your patients, just let us know. We can usually come up with good treatment plans for them to help resolve it. Now, acneiform rash is something that can wax and wane. So they might peak or might develop their first, kind of incidence of it about 2 weeks after starting. Then it resolves, but then 6 or 8 weeks later, it can kind of flare up again. So just because it happens once doesn't mean that it might not happen again. We have a nice health facts for you. So if you search EGFR in UConnect, you'll find this handout. I think this is really good for patients, and we often will give it to them after they start therapy. Here's just listed on the slide for reference of depending on the severity, what we can do. We've talked about, where's my mom? Do you mind shutting that door? It's a bit loud. Thank you. What we can do, we do a lot of topical steroids. You'll also see clindamycin used. We'll add on to steroids. If, you're kind of beyond and it's really severe, and I've seen very severe cases of acneiform rash, most often you're going to hold drug until it resolves, potentially dose reduce per their package inserts. You can switch from doxycycline to minocycline. Sometimes that can be helpful. Sometimes starting steroids can be helpful. I guess if you had a very severe grade, really bad grade 3 or grade 4, I almost would consult Oncoderm here because sometimes they'll have other things that they will use, like tretinoins, for example. Okay, segueing from EGFR inhibitors to capecitabine. Capecitabine is used for a variety of different indications. And I know Jess kind of talked about this yesterday, but from a clinic perspective, you'll see capecitabine in combination with radiation. You'll see capecitabine dose 2 weeks on, 1 week off. You'll see capecitabine dose 1 week on, 1 week off. You'll see it in a variety of different reasons. Listed here is supplied as 150 and 500 milligram tablets. My preference is to round to the nearest 500 milligram tablets. Oftentimes I find with 2 different tablet sizes at home for patients, they are making mistakes on their dosing, and you can usually get it pretty close to a 500 milligram tablet size. Warfarin is a big drug-drug interaction. It's a pain in the butt to monitor that INR, even if they're monitored through our system here. I've, in a 10-year career, maybe have had 1 patient, maybe 2, successfully be on capecitabine and warfarin without their INR going through the roof and needing lots of dose reductions. It's very important for patients on continuous dosing of capecitabine to be moisturizing their hands and feet because of that hand-foot syndrome, and we'll talk about that. There is the risk of diarrhea, and depending on your population, especially maybe a GI patient who's had some surgeries, that diarrhea can be significant. It's a low risk of nausea, but some patients still struggle with this, so making sure they have appropriate antiemetics, and then making sure that they understand hand-foot syndrome, which we're going to talk about. So capecitabine and continuous infusion 5-FU and other chemos such as Doxil. I don't know if anybody covers Doxil, but those can cause hand-foot syndrome. And what happens is it's this dryness and cracking and peeling on the palms of the hands and soles of the feet. Unfortunately, the symptom onset is quite variable. I kind of teach patients you got to watch it over time. Most likely as we're heading into winter months, as everything dries out, they have to be even more cognizant of it. But as you can see here on this individual's feet, they're red. Here's my hair. They're red, kind of inflamed and edematous, have this cracking and peeling. It can be very, very severe, unfortunately, for some patients, even after 1 or 2 cycles. Here's our health facts for you. If you search hand-foot syndrome, this will pop up in UConnect. Other things about hand-foot syndrome. We usually have available in clinic cotton gloves and little samples of like udder balm or bag balm. So if you're ever having a patient that is struggling, we can give those supplies to patients, which is really nice. And then the final thing about capecitabine is dosing seems to matter. So for some indications that their dosing is 1250 milligrams per meter squared, on a 2-week on 1-week off basis, I find those patients almost have the worst hand-foot syndrome risk versus patients that are on 825 milligrams per meter squared, twice a day in combination with radiation for only like 5.5 weeks. Those patients usually don't experience hand-foot syndrome, which is good. Okay, segueing into our VEGF inhibitors, I'm only covering 1 agent. This bevacizumab is an IV agent. There's other Me Too drugs like bevacizumab, but we predominantly use our IV VEGF inhibitor is Avastin or bevacizumab here. It's used for a variety of indications. You'll see it used in brain cancers, colorectal cancers, gynonc population. Not as common in that one though. So essentially these drugs work by binding to vascular endothelial growth factor ligand, and it prevents it from getting to the receptor. And therefore it decreases angiogenesis. So if a tumor cannot grow its own blood supply around it, it either causes stabilization of the tumor, so no growth, or potential shrinkage. When you affect angiogenesis, you're going to have angiogenesis-based side effects. So blood pressure issues, bleeding episodes, poor wound healing. And so I always think of bleeding and clotting issues with bevacizumab. With the hypertension, the biggest, usually you do not have a patient that skyrockets their blood pressure after 1 dose. It's usually not that fast, but you will see a small uptick every cycle in their blood pressure. And so that's something that you have to monitor over time. If you have hypertension, honestly, you treat the hypertension. You usually do not dose reduce. You might have to hold a dose of bevacizumab to get better control of the blood pressure, but you will be able to resume full dose. And then the other thing is usually this has to be held around surgical procedures. So if there's a port placement, you're going to see it held for either 2 or 4 weeks after that port placement to allow proper wound healing. A newer drug, an oral targeted drug that is used in GI cancers is called Lonsurf. So it's an indication in metastatic colorectal cancer, used it's like third or fourth line. It's usually our last line that we're using in clinic if patients aren't eligible for clinical trials. It's also used in gastric cancer, again, later lines. The dosing, it's 35 milligrams per meter squared, twice a day on days 1 through 5 and 8 through 12. That's what's going to show you in the package insert. It's a 28-day cycle, so kind of unique dosing. Most patients appreciate a calendar to highlight what days they should be taking this. In clinic, though, and there's kind of now data coming out for probably about 2 years now, we've actually changed how we've dosed it, and we dose it on days 1 through 5 and 15 through 19, so every other week. And this helps to reduce blood count issues. That's the number one thing you find with the days 1 through 5, 8 through 12, but once we've modified it, we've tended to have less blood count issues. Lonsurf, the latest in colorectal cancer, is it's actually in combination with bevacizumab, and bevacizumab is given every 2 weeks. So it usually lines up nicely for patients is that they start Lonsurf on the day that they get bev, and that's every 2 weeks. You got how this drug works. I didn't even go through that. So it's actually a combination drug of trifluridine and tipiracil. Trifluridine is a thymidine-based nucleoside analog, and it's incorporated in DNA, interfering with DNA synthesis. Tipiracil is a phosphorylase inhibitor, and it increases trifluridine exposure because it inhibits its metabolism. So tipiracil is not actually the active chemo agent. Biggest things, blood counts, there is a nausea and vomiting risk. Fatigue seems to be pretty high, but again, we're using these in patients that are already really heavily pretreated. At this point, too, they are usually seeing like a decrease in appetite and fatigue, and diarrhea can be associated with this drug also. Regorafenib, I struggled including this in the slide deck, but I don't believe Lindsay's going to cover regorafenib in her section on GU and lung. It is listed in the guidelines. This paper where colorectal cancer got its indication, this is a good paper to talk about the difference between clinical significance and statistical significance. I consider regorafenib a dirty drug, meaning that it has a lot of side effects and it's really hard on patients for not a lot of benefit. So if you're ever looking for a trial for that clinical versus statistical significance, this is a good one. The dosing, it comes as 40 milligram tablets. It's 4 tablets once a day on days 1 through 21 and then off for 28 days. There's data to show that tapering up on the dose tends to help ward off a lot of side effects. So for example, the 2 patients that I have on this now, we started at 2 tablets once a day. We tried to escalate up to 4 tablets and it didn't go well. One had unfortunate, a lot of blood pressure issues. The other one had the hand-foot skin reaction, which we'll talk about. Most often patients do not tolerate this full dose. And so please don't slam a patient with 160 milligrams. They're not gonna like you. So I usually start at about 80 milligrams in clinic and go up from there. Indications, colorectal cancer, HCC, and GIST is where you can use it. Again, it's not any preferred first-line option. It can cause hand-foot skin reaction. We're going to talk about that. Diarrhea, hypertension, rash, extreme fatigue. Again, because of how it works, it hits multiple different tyrosine kinase inhibitors. Because of this, it's not very targeted. It then comes with a lot of side effects. So what is this hand-foot skin reaction? So hand-foot skin reaction is distinct from hand-foot syndrome. You might hear people use those interchangeably, but they're actually different and you kind of need to manage them differently. So from TKIs, what can happen, like from regorafenib or other TKIs, is you develop almost calluses or blisters on the skin. And so it'll most often occur on pressure points. And so I'm rubbing my hands right now because I just had a patient who across both palms on its pressure points, he developed calluses from this drug. So what do you do? It depends on the grade and what it kind of looks like. You know, things kind of right out of the gate, you're going to avoid hot water or alcohol-containing products. Again, you want to try to protect those tissues, keep them as well moisturized as possible. Here's kind of where urea cream comes into play because it can help to break down those calluses. If they're only the calluses, people will use pumice stones to help gently kind of break down that skin. In some cases, if it's a blister, like, if you think of blisters when you wear too tight of shoes and it's like a fluid-filled sac, you're not going to use a pumice stone on those. Again, if that's the case, you're going to be holding drugs to allow those to resolve. You can use topical steroids. Most often patients need pain relievers, and then they need dose reductions of their drug because it will reoccur if you start back up at the same dose. Okay, moving into penigatinib, which is, oh gosh, this picture looks awful. I'm sorry, it looked better on my presentation. So it is approved for FGFR2 fusion cholangiocarcinoma. And I wanted to cover one drug for cholangio because it's kind of exciting. I've only probably used it 2 years in my practice. But as you can see, blurry, sorry, it hits this altered FGFR receptor here, which then prevents all this downstream signaling, and then it kills those little cholangiocarcinoma cells. The dosing is listed here, kind of unique, 13.5 milligrams by mouth once daily. This is cycle-based. They're on it for 2 weeks and then off for 1. Can be taken without food, again, for cholangiocarcinoma with this FGFR2 genetic alteration. Toxicities, fatigue, changes in electrolytes. I highlighted FOS because it's a big one, and we're going to talk about that more. It can cause diarrhea, nausea, vomiting, decreased appetite, mouth sores, nail changes. It's not a pretty drug, but it's a pretty efficacious drug, so that's why I wanted to cover it. Patient education, we're going to talk about FOS more coming up. Nausea, vomiting, those nail changes that can develop in very severe cases with nail changes where it's like brittle. They start to come off of the nail bed. They can get thicker. Usually, again, you're going to be sending them to Oncoderm for those indications. It can also cause eye changes. And so I highlighted here that patients have to become besties with their ophthalmologist because they need a baseline eval every 2 months for 6 months, and then every 3 months thereafter for however long that they're on the drug for. Okay. This drug can cause phosphate levels to go through the roof, and so you're monitoring them pretty frequently. We have them built out within our HealthLink beacon plans, but this is what you do depending on their level. So one of the patients that I've had, I remember hers used to sit between 7 and 10. Most often these patients are going to be on chronic phosphate lowering therapy, just like the phosphate binders that we use for patients with CKD. You're going to be using those. You have to do pretty intensive monitoring though, and when you start a patient, this will help you in terms of what to do and what level. Very interestingly, one of the patients that I had on this, because it's cycle-based, so that 2 weeks on, 1 week off, we got to a place where we were doing weekly FOSs, and she was only on her phosphate binder for those 14 days and then was off her phosphate binder for the week off, which was very bizarre because the drug company said usually you have to have the phosphate binder the entire time, but when she would come back to clinic, her phos would be too low, like critically low. So we had to kind of find a happy place with that. Now moving into another TKI, sorafenib, that's approved for HCC and GIST. Sorafenib used to be our gold standard for initial treatment of HCC, but it's now kind of worked its way down the pipeline, and it's almost like 3rd or 4th line, I would say, because lenvatinib, which Lindsay's going to cover coming down the road here, and atezo, which is immune checkpoint inhibitor in combination with bevacizumab, is usually the first thing you're going to see an HCC patient start on. It's 400 milligrams by mouth twice a day. It comes as 200 milligram tablets. There's data to show that you should also taper these patients. So starting, for example, at 200 milligrams twice a day and then bumping up to 400 and then 200 and then 400 and 400, again, because of the TKI-based side effects. Just like regorafenib, this is a multi-kinase inhibitor. It binds to tumor growth and it inhibits tumor growth and angiogenesis. Again, looking at all the different intracellular RAF kinases it hits and the cell surface kinase. So VEGF, PDGFR, FLT3, which is a heme thing, but it still can hit that. Toxicities based on all these targets, you can imagine hypertension, hand, foot, skin reaction, diarrhea, electrolyte issues. Interestingly, you can sometimes see decrease in blood counts with this one, rash and arthralgias. Patient education, very similar to other drugs in terms of the hand-foot skin reaction, monitoring their blood pressure. I didn't actually talk about that. So on patients that actually start these therapies, if they don't have baseline blood pressure issues, usually across the board, they don't need to be monitoring their blood pressure at home because they're not already at risk of having blood pressure issues. If you have a patient that's borderline, already on antihypertensives, those are the patients that I say you need to get a blood pressure cuff and probably start monitoring yourself daily just to make sure that you unfortunately don't skyrocket. The number we usually say to call us if it's consistently above 160 over 100 is usually when we say to patients we want to hear from you because we usually need to do something about those patients. Sometimes we escalate their home antihypertensives. Sometimes we are starting a new antihypertensive in them. Those GI drugs in a nutshell, again, there's a whole bunch more that we didn't talk about or you've already reviewed about in immune checkpoint inhibitors and the cytotoxic agent section. Moving on to breast cancer drugs. So CDK4/6 inhibitors, these really did revolutionize the treatment of patients with metastatic breast cancer that are ER and PR positive for initial treatment. How they work, this actually highlights a lot of different drugs that we use in breast cancer. That's why I like this drug. But CDK4/6 inhibitors, they inhibit right here. So we have palbo, ribo, and abema. When it inhibits this, you can't get downstream DNA replication, and therefore the breast cancer cell cannot survive. So I mentioned the three that we have. Palbo was the first drug on the market, and it really did revolutionize the treatment of those newly diagnosed metastatic ER/PR positive, HER2 negative. It's 125 milligrams by mouth once daily, days 1 through 21, every 28 days. Then came ribociclib. That one's 600 milligrams by mouth once daily, days 1 through 21, every 21, again, cycle-based. These two need to be cycle-based because of blood count issues. Ribo has to be taken on an empty stomach. Again, there can be drug interactions across the board with these, so always appropriate to monitor. Here are your tablet and capsule sizes. Then came abemaciclib. This one is twice daily dosed. It has to be taken with food. Again, drug interactions are here. Where you're going to see these used, so all still have if you look in the guidelines, palbo, ribo, and abema are all listed as potential initial therapy for metastatic ER/PR positive, HER2 negative. Unfortunately, though, I think it was at a recent ASCO, ribociclib just came out with overall survival data where palbo doesn't, and so you're going to see more patients now if you're rotating through breast cancer clinic in that setting start ribociclib. It's kind of unfortunate from my perspective because I don't think ribociclib's as well tolerated, and I think there's some folks on the line who would probably agree with me. We've had some rashes. You have to monitor EKGs. It's a little bit more intense. Versus palbociclib, it's the longest on the market. We have really good experience with it, and in general, it's a very well tolerated drug. Abemaciclib, again, can be used in the metastatic setting. You are going to see it a lot in patients with high risk ER/PR positive early stage breast cancer as adjuvant therapy for 2 years after they've completed their chemo and potential radiation. So that's where you're probably going to see this one used coming down the pipeline. We have a lot of patients on this, of course, given that indication. Adverse effects listed here. Dose-limiting toxicities for both palbo and ribo is neutropenia, and so you need to be monitoring blood counts every 2 weeks for the first 2 cycles. Abemaciclib, on the other hand, the dose-limiting toxicity is diarrhea, and it can be pretty significant, so being cognizant of that. Abemaciclib also, where's my pointer? Crosses the blood-brain barrier. So the one time where you might see abema right out of the gate in a metastatic patient is if they potentially have any brain metastases. So you might see that. So let's go through a patient case with a patient with newly diagnosed metastatic ER/PR positive HER2 negative breast cancer. So she was diagnosed in 2019. She was at that point in time initially started on palbociclib and letrozole. Looking here, the package insert is really nice because it says what you should do based on heme toxicities. Again, what's really nice is they'll include, I don't know if we can see this on the bottom here, grade 1 what a grade 1, grade 2, grade 3 are, and what you should do if you should have a dose reduction. So she starts therapy. She gets cycle 1, day 15 labs. It reveals the following. She has an ANC of 400. So what grade is she experiencing, and what is the most appropriate action? So if we go back here, her ANC is 400, which puts her at grade 4, right here, in what you should do. Withhold until you're recovered to grade 2, which is an ANC of 1,000 to 1,500. So looking at our answers here, there's only 2 grade 4. You're going to withhold, decrease dose, and restart then less than a grade 2. Oh, there we go. So her neutropenia resolved. She resumed palbociclib at 100. That's the next dose reduction level, days 1 through 21 every 28. She returns for cycle 2, day 15 labs. Wah, wah. Her ANC is 250 this time. Her palbo then was held. Her neutropenia resolved. We dose reduced to 75, which is the lowest dose that you can do. And she returned for cycle 3, day 15 labs. Her ANC did not like palbociclib whatsoever. So again, it's the rate limiting or dose limiting toxicity. And some patients actually cannot maintain the first or second dose reductions. They have to sometimes start like the lowest possible dose, especially if they've maybe seen previous chemotherapy and their bone marrow has already kind of been hit by stuff. So we permanently discontinued palbo at that point. We discussed, thankfully, there's other CDK4/6 inhibitors we can use. We did a BEMA for her, and of course, diarrhea is the dose-limiting toxicity with that. Was really cool, and I still have my fingers crossed. She remains on abemaciclib 100 milligrams twice a day. She did need a dose reduction initially because she had diarrhea and a little bit of neutropenia. It wasn't as bad as palbo, but she still maintains on this to the day, which is really, really amazing for her, especially since we had such a rocky start. Moving into another drug, alpelisib. This is approved for ER/PR positive, HER2 negative, but you need this PIK3CA mutated breast cancer. So most often you're going to see that done when they're initially diagnosed with metastatic breast cancer. This is not used in first line. This would usually be reserved in these patients if they have this mutation after a treatment with a CDK4/6 inhibitor. It's 300 milligrams by mouth once daily with food. It's chronically dosed, so it's not cycle-based, which can be nice for patients. Unfortunately, though, it comes with some side effects, including hyperglycemia, diarrhea, rashes, other like LFT issues can happen with this one, mouth sores, but the biggest thing that we usually see in clinic is hyperglycemia. So before you initiate this therapy, you need a fasting glucose and A1C before initiation. They do recommend to optimize blood glucose before initiation, but sometimes when you're trying to get a patient on therapy, you might not have time to fully get that A1C to goal, and we should be reaching out to the PCP, especially if they're already coming in on some blood glucose drugs. It can also cause rashes. So based on this SOLAR-1 trial, they did use an antihistamine to help to prevent the rash. It's not perfect. I just recently had initiation of alpelisib, and the patient unfortunately developed a full body rash despite being on an antihistamine. What's very concerning about rash from alpelisib is you have to be aware that it can cause Stevens-Johnson and TEN syndrome, so the more severe rashes. So making sure a patient is aware of that and to report in if any rashes do develop. It's very important to monitor, well, built in your treatment plans is all the monitoring that you should do for fasting blood glucose. Sometimes we're intensifying agents for patients. Sometimes we are starting agents. We do know, and there's data that's coming out, that if patients are pre-diabetic or have diabetes, they are at the highest risk of having blood glucose issues. So being aware of that is also very important. So how do you monitor and what should you do if a patient develops hyperglycemia? So really your cutoff point of doing stuff, you can do stuff within grade 1s, and if you're on a clinical trial versus standard of care drug, you most likely, if you have a fasting glucose of above the upper limit of normal to 160, I would say you better be looking at starting metformin pretty quickly. Fortunately, metformin doesn't come without its side effects. So being, cognizant of, well, what's causing diarrhea, the metformin or the Alphalissa when you start it? But really when you might be doing furthermore intensifying things is if that fasting glucose is 160 to 250, that's a grade 2. There's very specific recommendations on what to do. If your fasting is 250 to 500, I've seen this. Most often you're going to need to hold drug and really intensify therapy and getting in touch with that patient's PCP for potentially, metformin is usually not enough at this point, either starting like sulfonylurea or there's a whole bunch of new fancy diabetic drugs that I'm not going to pretend to be an expert in, or even starting insulin at that point in time. So due to hyperglycemia from Alphalissa, which of the below would be the best treatment option for a grade 2? A, start insulin glargine. B, start metformin. C, start glipizide. Or D, start insulin short-acting with a sliding scale. And this is for a patient who is not on anything at this time. What would be the best option?
B.
Yes, B is the correct answer. Starting metformin with titration for those patients. Usually if you're maxing out on metformin and you still have glucose issues, that's when we start a sulfonylurea. So glipizide would then be added to that before starting insulin. Okay, moving on to everolimus. This is an mTOR inhibitor that has a wide variety of indications. It is used in ER/PR positive HER2 negative breast cancer, usually in combination with either exemestane or fulvestrant, for example. Dosage forms are listed there. It comes as little dose packs. The biggest mTOR inhibitors as a class have class side effects. So mouth sores, diarrhea, nausea, vomiting, fatigue. There's a pneumonitis risk. Rash can happen. The biggest one, though, is the mouth sores, and it can be very, very extreme and painful for patients. So this is where this SWISH trial came into play, and this is built within our treatment plans. So they enrolled patients with metastatic breast cancer who started everolimus. They started dexamethasone rinses. Patients are instructed to swish for 2 minutes and spit. They do this 4 times a day for 8 weeks. You can continue it beyond 8 weeks, but at least do it for that. What they looked at is the grade 2 or worse mouth sores by 8 weeks versus historical controls. And so what they found was that the grade 2 was 2% versus 3% of patients. So only 2% of patients had grade 2 or worse mouth sores, which is a really big deal for everolimus. And so built in your treatment plans, you're going to see those dexamethasone rinses for patients, and they should do them. The other thing, and this is just anecdotal, one of those like pearls, the tablets come in those little blister foils. And so they shouldn't open them until that they're actually going to take them. Now, some patients have found that if they kind of hide the tablet in like a little piece of banana or a marshmallow, almost to avoid that tablet from hitting their throat, tended to help them with mouth sores. And again, the mouth sores can be so significant that, is it crazy to do it? No, because you can take it with food, and it actually helps to prevent nausea usually in those cases. So sometimes instructing patients to do that to help to protect those tissues, do it. Again, just anecdotal. I know a couple other centers that instruct their patients to do that also. So what do you do? Dex rinses, you eat soft foods, good oral hygiene is important. So making sure that they're brushing with a soft bristle toothbrush, mild toothpaste, avoid alcohol-based mouthwashes, those can sting. Avoid things that irritate the mouth, so spicy foods, unfortunately, anything crunchy that can cause damage to those tissues until the mouth sores resolve. Now, the mouth sores will usually happen within those first 8 weeks. It usually resolves. You don't always need to dose reduce, but if a patient has their entire mouth is covered in mouth sores, usually you have to hold therapy, allow the mouth to recover, and then dose reduce to a lower level. So I haven't talked about anything about HER2 targeted therapies, the other big class of drugs that we have for breast cancer patients. So drugs that are used with HER2 patients, the first one to talk about, trastuzumab, that guy was the first on the market, probably almost 2 decades ago, essentially revolutionized the treatment for patients with HER2-positive breast cancer. And then pertuzumab. Listed here on the slide is dosing, so both need loading doses. So trastuzumab is 8 mg per kg once, followed by 6 mg per kg. Pertuzumab is 840 milligrams loading dose, so a flat dose, followed by 420 milligrams every 3 weeks thereafter. Pertuzumab is never used alone. It is always used in combination with trastuzumab. The biggest things from these drugs can be a decrease in the left ventricular ejection fraction, so you have to monitor echoes and MUGAs. There is, I call it the great debate for HER2 agents of whether you need to or how much monitoring you need to do for patients with metastatic cancer, but built within your treatment plans for a patient on curative intent treatment is going to tell you what to do with those. In terms of side effects, it's really difficult to tease out because trastuzumab, when it's studied with cytotoxic agents, you're going to look at the adverse effects in the package insert and be like, holy cow, there's a lot of adverse effects. But honestly, those are mostly related to the cytotoxic chemotherapies. And once a patient, for example, is on trastuzumab to complete a year of adjuvant treatment, they really don't have side effects. The biggest thing is going to be watching their echoes or MUGAs, for example. Pertuzumab, we have found that when it is in combination with trastuzumab, does have a risk of diarrhea. Now, when you think of cytotoxic agents, you kind of know when the diarrhea is going to happen. So, for example, irinotecan, kind of happens within days 3 to 7 after therapy. This diarrhea can develop at any point in time that these patients are on the drugs. So it might not happen within the first week after the first dose, but it can happen 16 days after their 3rd dose. It can just be very bizarre. So patients need to be educated about appropriate Imodium use and to call in if they're having issues or struggling with that. So how do these drugs work? Here's your little HER2 receptor on the outside of the cell. They bind to different domains. And so listed here, you'll see, here's where your trastuzumab, here's where your pertuzumab. If you look here, it binds to this HER2 subdomain 4 and inhibits its activation of HER2. Pertuzumab binds to subdomain 2 and it inhibits activation of HER2 by interaction with the HER1, 3, and 4 molecules. So a little bit different. They don't work the same. That's why they need to be used in combination and why pertuzumab cannot be used alone. So we talked about left ventricular ejection fraction. This is my little plug for cardio-oncology. We do have Dr. Ewer here, who is our cardio-oncology expert. There are new guidelines, which is why I put them in here. It's really exciting. It's actually very comprehensive. I was going through them yesterday looking at this. So if you're ever wondering about cardio, risk factors from the drug and what to do, boom, here's your guidelines. Look it up. It's really, really cool. I've not combed through them fully yet, but this is kind of important because we've been waiting for these for a while. In terms of things that you can do, I really liked this picture taken from a different, one of the US cardio-oncology based things of what you can do. We try to prevent, you optimize risk factors, what you should do for monitoring and surveillance, and then monitor your cancer regimens. I think the biggest thing in breast cancer, we know, for example, reductions in left ventricular ejection fraction from trastuzumab and pertuzumab, those are not permanent. Those are reversible versus your anthracyclines that you guys have already covered. That cardiotoxicity, unfortunately, can be permanent. More research, especially if you look at some of the latest breast cancer trials, they're trying to do anthracycline sparing regimens because we know those come with that cardiovascular risk and those are permanent. 2 other HER2 targeting agents, adotrastuzumab and tansine, also known as Kadcyla, and famtrastuzumab deruxtecan, also known as Enhertu, are 2 other HER2 targeting therapies. These drugs are drug antibody conjugates. I find these drugs to be really, really fascinating and I always geek out with patients. But essentially you have a HER2-directed molecule and then you have different chemo agents. So for example, on Kadcyla, it's a microtubule inhibitor versus the deruxtecan. This one has a, where is it listed? A topoisomerase 1 inhibitor. Again, both of those inhibit cell replication and therefore results in cell death. So essentially they target that HER2, the chemo is internalized, and then takes care of that DNA and it dies. These drugs do, although they are HER2 targeting, these do have side effects associated with them. Our patients that are on Kadcyla, again, you will see this in the metastatic setting and in patients who have residual disease when they're getting curative intent chemo after surgery. Biggest thing, thrombocytopenia and anemia, peripheral neuropathy, so especially for a patient who's already had a taxane and then they get to Kadcyla, that can worsen. In addition to interstitial lung disease and pneumonitis, this is more rare, but still can occur. In HER2, this one can cause neutropenia more often and thrombocytopenia. This still does have this interstitial lung disease and pneumonitis risk, and this one can cause more increases in LFT, so being aware of that. It also contains polysorbate 80, which has a risk of infusion reactions associated with this drug. In HER2, recently, in terms of a metastatic setting, is now used behind a taxane, Herceptin, Perjeta backbone. It's now second line versus Kadcyla got bumped to third line for metastatic HER2 positive breast cancer patients. In HER2 also is used in esophageal and gastric cancers. So we do test for the HER2 in those patient populations, and we'll use these drugs if needed. I didn't mention that with trastuzumab and pertuzumab, but you will see those used in other different solid tumors that might express HER2. So there's different niche indications with yours. The predominant population still, of course, is our breast cancer population. I didn't run over this time. There is a whole bunch of different drugs used for these different indications. Drugs are now becoming less disease specific, so not just a HER2 breast cancer, you might see them used in a metastatic HER2 positive gastric cancer patient, for example, so being cognizant of that. Knowing your class effects will help you in terms of side effect management, and then use your neighborhood friendly pharmacist. What questions do you guys have? I did that good today. If ever any questions, please feel free to reach out, guys. Thank you.